All right, let's get us started. Good morning, everyone. Welcome and thank you for joining the first of a two-day training with Bucks County on screening, supporting, and navigating adolescents within the behavioral health system. My name is Leah Chapman. I am a project manager here with Magellan. I'll just go over a few housekeeping items before we get started today. This training is being recorded. All of your lines are currently muted. We ask that you join on video today whenever possible. I know that sometimes we have to kind of go in and out, so please join us when possible. We will be taking questions today at the end of each section, and at that time, questions can be chatted or asked verbally. And at the end of the webinar, I will be placing a link in the chat box to complete a post-test and the survey to obtain your certificate of attendance or CE certificate. I will also email out today the resources and the PowerPoint from Dave in addition. If we have any technical issues, please bear with us. Sometimes Zoom can have some moments, we could say. These two webinars that we have this week and next week will help professionals screen and identify adolescents with co-occurring substance use and mental health needs and connect with necessary supports and services. I am now going to hand the training over to Dana Lombardi to get us started.
Hi, good morning, everyone. On behalf of the Bucks County Department of Behavioral Health and Developmental Programs and Magellan, we're pleased to have you join us today. My name is Dana Lombardi, and I'm a clinical project manager with Magellan, and I'm working as one of the leads on this important project to highlight the need for assessment of substances for youth and young adults in Bucks County. Monica Stefanik, the children's manager from the Bucks County Department of Behavioral Health and Developmental Programs, and also my co-lead, and I have been working on this topic for the past several years to try to gain a better understanding of the system needs as well as the adolescent and young adult needs in our community. In the past several years, there have been a very small number of youth who have accessed substance use treatment, which seems to be in direct conflict with the use that is being reported by the youth themselves. On the other hand, we know that there's a much higher number of adolescent and young adults who receive support from the mental health system, which is kind of why we invited all of you here today. A number of scientific studies have identified a link between mental health problems such as depression and the use of alcohol, tobacco, and other drugs during adolescence. Depression is the #1 risk factor for suicide by teens, a risk that's amplified in teens self-medicating with alcohol, tobacco, and other drugs. Based on all this information, we wanted to bring you together and thought it important and a nice way to celebrate Mental Health Awareness Month and Drug and Alcohol Prevention Week in this co-occurring approach. National Prevention Week is a national public education platform bringing together communities and organizations to raise awareness about the importance of substance use prevention and positive mental health. The training today, like Leah had said, is part 1 of a 2-part training series to review how you can help to identify youth who are using substances or at risk for substance use. We know this is sort of a hard conversation to have, and we want to help you to feel empowered with the tools you need to feel confident in beginning this discussion with the youth that you support. I can tell you that I'm currently enrolled in a Penn State training series on SBIRT, which is what we're going to review today. And my biggest takeaway thus far is that being able to have these conversations really and just discuss them with the youth that you're working with is an intervention in and of itself, and it can make all of the difference. We've learned from community surveys that about 75% of parents indicated they're unsure if their child's mental health provider has talked with them about substance use. We hope that the information and the framework that we're presenting to you today will assist you in having these conversations and making the impact on the lives of the young people you're working with. Part 2 of the training series is going to be offered on Monday, May 16th, so next week, and we'll review at that time what to do with the information you receive after having the conversations with the youth. So today we're going to talk about how do you have the conversation, and then next week we'll talk about what do you do with the information that you receive during that conversation. I'm now going to hand the training over to our keynote speaker, Sandy Sini. Sandy is a Pennsylvania licensed clinical social worker, certified advanced alcohol and drug counselor, and certified clinical supervisor. She's been working with individuals with substance use disorders and co-occurring mental health disorders for over 25 years. For the past 22 years, Sandy has worked with individuals with opioid use disorder who are utilizing medication-assisted treatment as part of their recovery journey. She's currently the program director of an outpatient methadone maintenance clinic in Philadelphia. Sandy served on the Service Access, Best Practices and Treatment Providers Subcommittee of the Mayor's Opioid Task Force in Philadelphia. She's also a field placement supervisor for graduate social work students and a trainer and speaker on topics related to addiction, recovery, harm reduction, and treatment interventions. So with that, I will hand it over to Sandy. Thank you.
Thank you, Dana. I successfully unmuted myself, so first challenge overcome. So I'm very excited. We're off to a good start. So good morning, everybody. And I just want to thank Magellan and the other organizers of this event for inviting me to be part of this, what I consider to be a very important and very timely event. Because if ever there was a time to talk openly and directly about the intersection between adolescent mental health and substance use and how to address it effectively, it's now. While overall, I think many of us can say that the pandemic has been an unpleasant and stressful time, one thing that seems to have come out of it is people's willingness to talk more openly about their struggles with mental health issues and to some degree, substance use or abuse. It also appears to have made it a little more socially acceptable to talk about going to therapy. So much like the effects of the opioid epidemic, unfortunately, it sometimes takes a shared tragic experience to bring people together and allow them to be more vulnerable about their struggles. So as someone who's worked with hundreds, if I hate to say maybe thousands of adult clients with substance abuse issues over my career, it's hard not to see some patterns and some themes emerge from the conversations. The first I want to mention is the age of onset of alcohol and substance experimentation and what I've heard from my clients. So many adult clients tell stories of sneaking alcohol as young kids, sometimes even before the age of 10, smoking cigarettes or marijuana as young preteens and teenagers, sometimes even using with family members because it's considered acceptable. And then falling, unfortunately, into some unhealthy peer groups as adolescents and seeing their substance use increase, not only in frequency and amount, but maybe then progressing into some harder substances. The second thing I've noted is the degree to which a lot of these clients describe experiencing symptoms of what we would probably consider to be depression, anxiety, ADD, and ADHD as young people, and how they felt that their substance use helped manage or even alleviate a lot of these symptoms. By the time I'm meeting with these individuals, unfortunately, their substance use has progressed into a full-blown addiction, and they're experiencing the unfortunate consequences that often result. Things like homelessness or unemployment, periods of incarceration, significant health issues, family estrangement, just to name a few. So they say hindsight is 20/20, and I can't help but wonder as I sit with these adult clients that if someone had intervened and they had received maybe more appropriate treatment at a much younger age, would their life have turned out differently? And the answer is probably and sadly yes. But hindsight's only helpful if you're able to take what you learn and use it moving forward to affect positive change. So what I want to talk to you about today is the opportunity that we have before us to shift the way we work with adolescents and young people to create a collaborative behavioral health system with this no wrongdoer perspective, meaning that regardless of what symptoms a client walks in the door of our agency with, whether it's mental health or substance use or both, we're able to appropriately assess and, if we can, treat or refer for treatment that meets their needs, not only in a timely manner, but concurrently. So here's the problem. Historically, the behavioral health system that we work in has really separated mental health and substance abuse treatment into very separate and distinct silos. We have different regulations, we have different payment systems, we use different language, and oftentimes we use different lenses with which to view the client sitting right in front of us. When I started my career in substance abuse treatment almost 30 years ago, not only were we not trained on co-occurring disorders, but we were actively discouraged. Yep, you heard me right, actively discouraged from talking about mental health with our clients. We were instructed to tell the client that they needed to address any feelings of depression, anxiety, or the like at their next appointment with their mental health counselor if they had one. The words, and I quote here, "We don't do that here," actually came out of my mouth. I can't fathom anybody in behavioral health treatment saying these words today. And I kind of recoil when I think back to the early part of my career when those words did come out of my mouth. At that time, this is back in the mid to late 90s, a person who had mental health and the substance use disorder was said to have dual diagnoses. So while this was progress in that we recognized the existence of both illnesses, it still gave the impression that the individual had these two very distinct disorders that weren't really connected, and therefore integrated care was not considered or even offered. Individuals were often referred to a separate treatment program, most often at separate agencies, with very little, if any, coordination between the two services. So in recent times, luckily for us, there's been a shift, and rightfully so. We now take a holistic, biopsychosocial, recovery-oriented approach to care. One that really asks us to view the person sitting in front of us as a multidimensional person. Because here's the reality. Human beings, as we probably all well know, are very complex, layered beings. And they don't often present at our agencies and organizations with just one distinct symptom. Now, they may come in reporting only one concern or one presenting problem, but there's typically multiple issues going on that don't fall neatly into one category or box. But we really don't discover these until we begin to scratch the surface and have conversations with the client. So when young people walk through our door, regardless of how they come to us, how they're referred to us, it's often at a time of extensive crisis and confusion. Okay? They're looking for someone to provide them with some clarity, some hope, and hopefully some direction. And it's our job to provide them with that. And the best way to do that is to get a comprehensive understanding of their experience and then provide some logical next steps with empathy and support. So let's be honest, adolescence is a really complicated time, to say the least. It's a time fraught with uncomfortable change and transition, and these can be physical, these can be social, mental, and emotional. And oftentimes what can appear to some people as, quote, typical adolescent behavior or typical adolescent moodiness is actually symptoms of an undiagnosed mental health or substance use disorder. So we know from the literature that there is, as Dana mentioned, a high rate of comorbidity between anxiety and depression, particularly major depressive episodes, and alcohol and illicit substance use among teens. And shockingly, suicide remains the second leading cause of death among young people between the ages of 10 and 24 in this country. Research also shows that there's a strong relationship between suicidal ideation and suicide attempts when there is the use of alcohol, tobacco, or other substances involved. Unfortunately, though, we are a country that's currently experiencing significant treatment gaps when it comes to treating co-occurring disorders. According to the 2019 National Survey on Drug Use and Health, which is a national survey done with people 12 years of age and older, 9.5 million survey participants, that's right, 9.5 million survey participants over the age of 18 reported that when they had a mental illness and a co-occurring substance use disorder, 90% of them, which is roughly 8.5 million people, reported that they received no treatment at all. For those reporting a singular substance use disorder or any type of mental illness, 89% and 55% respectively reported receiving no treatment. Those are some staggering figures for a country like the United States. Unfortunately, for adolescents, the statistics are pretty similar. In one study I read recently, it found that between the years 2011 and 2019, less than 12% of adolescents with major depression, which we know is a significant risk factor for addiction, and substance use disorder, actually received treatment for both disorders. Less than 12% of adolescents. So you can see there's a huge gap between what's happening and what we're providing as far as treatment in this country. Now, this was all prior to the onset of COVID-19. And as a result of the pandemic, increases in substance use, mental illness, and suicidality are expected to be found among all age groups. COVID-19 especially exacerbated pre-existing challenges that a lot of our youth face. Since the start of the pandemic, rates of psychological stress among young people have increased dramatically due to social isolation, loss of their daily routines, and traumatic grief. The pandemic heavily impacted those who are already considered most vulnerable, like youth with disabilities, racial and ethnic minorities, the LGBTQ population, and other marginalized communities. So you see how this can further impact the chances of substance use or misuse or abuse. So why is adolescence such a critical time to address substance use? Well, that's a good question. But before I give you some information on the adolescent brain, let me give you two pieces of significant information that I think really encapsulate the issue. First, it's well established in the literature that drug and alcohol use prior to the age of 18 greatly increases the likelihood of an individual developing a substance use disorder in adulthood. Secondly, accidental drug and alcohol poisonings requiring some type of emergency treatment or deaths by overdose are dramatically increasing in this country among our young people. So you see, we simply can't wait for later or another time or a better time to consider doing more effective treatment. So for those of you who work with or maybe even have teens and young adults in your household, or for those of you lucky enough to even remember your own adolescence, you know that trying to understand why young people do what they do can often be frustrating and mystifying. How many of us have heard or even said the phrase, "What were you thinking?" I know I heard that a lot as a teenager, but what were you thinking? Because it appears that the average teenager isn't thinking about their behavior or their consequences. But this isn't exactly true. They are thinking, but their brains are just working a little bit differently than the way adult brains do. The teenage brain appears to be a lot more sensitive to the neurotransmitter called dopamine, or what a lot of us refer to as the happy chemical. And the growth of more dopamine receptors during adolescence and the enhanced dopamine supply provides a feeling to younger people that adults just don't experience when they engage in the same type of activities. So while there are a lot of healthy and safe activities that can increase dopamine levels, like running and exercising or listening to music, there's also some negative ones like using alcohol, nicotine, and drugs. Unfortunately, it's this reaction to dopamine that makes substance experimentation and use attractive to young people. Many experts agree that complete brain development doesn't happen until our late 20s. For a long time, we were saying about mid-20s, and unfortunately, it's edging closer to late 20s, closer to 30. So to put it plainly, the adolescent brain is a brain very much still under construction. The prefrontal cortex, the part of the brain responsible for reasoning and judgment and decision-making, is unfortunately the last part to develop. And this makes adolescence a crucial time because it's a time driven by the limbic system or the midbrain that really craves pleasure-seeking and risk-taking activities, as well as acceptance from their peers. So it's also important to understand that the brain at this time is going through a process called pruning. And this is a process by which the brain decides which neural connections of the millions that have been developed through childhood should stay and which ones should go. So basically, this is the use it or lose it principle. So for young people actively using substances like alcohol, tobacco, drugs, these pathways are unfortunately the ones being reinforced, so they're more likely to be kept and then contribute to long-term substance use and addiction. The literature has well established the link between mental illness and substance use disorder and how they share many of the same risk factors. Both are caused by overlapping factors like genetics, epigenetic vulnerabilities, issues with similar regions of the brain, and environmental influences like exposure to stress and trauma. It's estimated that anywhere between 40 to 60% of an individual's vulnerability to substance use disorders is attributable to genetics alone. Environmental factors like chronic stress, early exposure to drug and alcohol, or traumatic experiences greatly alters the functions of the neural circuits in the brain and can ultimately impact behavior. So I'm sure many of us on this webinar have heard of the Adverse Childhood Experiences Study, otherwise known as ACEs. And this was a study conducted back in the mid to late 90s that looked at how exposure to certain events prior to the age of 18 impacted individuals later in their life. And these events included things like physical, emotional, and sexual abuse, physical and emotional neglect, mental illness, substance abuse, and domestic violence in their household, parental separation and divorce, and incarceration of a household member. The results of the ACEs was startling. For individuals who scored a 4 or more out of the 10 questions, these folks were found to be 7 times more likely to develop an alcohol use disorder, 10 times more likely to inject street drugs, and 12 times more likely to attempt suicide. One of the most striking aspects of ACEs was that the study participants themselves. Of the over 17,000 people included in the study, most were middle class, 75% were white, 36% had some college education, and 40% had a college degree or higher. These were not the people we previously typically perceived as being higher risk for behavioral health issues. Previously identified risk factors for behavioral health issues, like being a minority, living in an urban area, or being part of a lower socioeconomic status, are still present. But there's also a subsequent ACE study called the Philadelphia ACE Project that was done in 2013 that expanded the influences on our young people and looked at the impact of exposure to bullying, community violence, neighborhood safety, racism, and living in foster care. This later study found that 37.3% of participants had an ACE score of 4 or more, compared to 21.5% from the original study. So while it would seem logical that young people living in dangerous neighborhoods or living in foster care are more at risk, we're unfortunately also starting to see some new trends. Youth from suburban areas and higher socioeconomic status are reporting increasing rates of anxiety, depression, and substance use due to real or perceived pressure to achieve academically and athletically. So I'm sure you can start to see why doing assessments that really incorporate questions about family history of mental illness and substance abuse and intergenerational trauma are imperative. Additionally, asking questions about what the adolescent may be seeing or experiencing in their home or community currently is also vital. And here's a little tip that I learned years ago. If you ask people about trauma, they don't really talk about trauma because it's become so normalized to them. Ask people about their experiences and you're more likely to hear about trauma. So the ACEs gives us a window into the potential future of our youth. It's like a crystal ball, and we don't get a lot of those. So we don't really want to discount what we know from the study because it's really helping us to look forward and see what the future of these young people could look like. Unfortunately, the predictions are related to really unhealthy and sometimes devastating physical and behavioral health issues. But by opening that door, it gives us an opportunity to address topics that we don't often discuss and to help clients understand how their environment can impact current behavior and how current behavior can set their life on an unhealthy path. It also gives us an amazing opportunity to change the trajectory of this young person's life. So getting an honest, thorough picture of what is going on in a young person's life is very important when we want to determine the course of treatment, even when they are cautious about answering our questions. Asking young people direct and, yes, sometimes very difficult questions, pardon me, is necessary. The reality is that most people, and this is especially true for young people, won't volunteer information about their substance use or misuse unless they're directly asked. And this could be for a number of reasons. It could be because they don't actually recognize it as an issue, what most of us in this behavioral health world would call people in contemplative stage of change, or they're concerned about getting in trouble with their caregivers or the authorities, or fear that they'll be given a label that comes with a lot of negative connotation. So some of the warning signs that you can listen for that could indicate that the adolescent may have a substance use disorder, they're not directly reporting, include changes in their behavior, both at home and at school, changes in academic performance, losing a job, change in their friend or peer network, expressing less interest in sports or activities, or becoming defensive or even denying substance use. Of course, being able to get collateral information from their family or other involved adults during the assessment process is always helpful, but we want to be mindful that a young person may not want their family involved, at least initially, due to fear of consequences. So when it comes to co-occurring disorders, people sometimes liken it to the question of what came first, the chicken or the egg. Did the mental health illness precede the substance use or vice versa? The reality is, it doesn't really matter. For individuals with co-occurring disorders, it's not necessarily the sequence that matters, but the treatment. In this case, both should be considered primary and both require equal and integrated treatment. Issues to consider and explore with that person include whether the substance use may be a pattern of self-medicating a mental health issue, or whether the presenting mental health issue may actually be a substance-induced disorder. Sadly, one of the biggest barriers to treatment continues to be the stigma surrounding behavioral health issues. While we've definitely made some progress getting information out to the public, we still have a long way to go. People are often fearful of the stigma associated with behavioral health diagnoses, and this is particularly true when it comes to substance use disorders. In recent years, how many public figures and celebrities have come forward to bravely talk about their own struggles with mental health issues? Yet, we don't often hear about their struggles with addiction until either they get arrested or worse, die. So a conversation often heard in adolescent treatment facilities is that clients and their parents would rather the child be treated for a mental health issue than a substance use disorder for fear that the child will carry the label of, quote, addict for the rest of their life. So it's up to us to help our clients understand the relationship between and the risks associated with mental health and substance abuse. One way that we can start to reduce stigma about substance abuse is by changing the way we talk about it. We need to speak about it as the disease we understand it to be, and not some moral failing or personal weakness or lack of willpower. Instead of using words like addict or alcoholic, we should be using terms like person with a substance use disorder or person using substances. And instead of phrases like dirty and clean urines, we should be talking about negative and positive drug tests or toxicology tests. The more we can help people understand that addiction has been well established as a disease, much like diabetes or even heart disease, the more we can generate acceptance and consequently make treatment often less stigmatizing. So as we've established, adolescents are quite different than adults, and therefore their treatment needs need to reflect that. Effective adolescent treatment for co-occurring disorder requires what I call the thirds, or a three-prong approach to treatment. First is family involvement. Mental illness and substance abuse affects the entire family system. So the family really needs to be included in the treatment process so they can better understand their loved one's disease and how best to support them in their treatment and their recovery. It also allows for education and exploration around mental illness and substance abuse that may actually be occurring or has occurred in other generations of the family. The second piece is psychoeducation. And for those of us in this field talking about co-occurring disorders and receiving training on the most current trends and practices is pretty commonplace. But to the average person or family, this is new, uncharted territory and can really bring up a lot of confusing feelings. It's our job to help young people and their families navigate this world. And finally, the third piece, which is equally important, maybe even slightly more important, is the social and peer system. For most young people, acceptance from their friends and peers is paramount to just about anything during adolescence. It can be a great source of anxiety and fear as well. Adolescent treatment would be remiss if it did not address clients and helping them understand the dynamic between them and their peers and helping them make healthier decisions and finding a peer group supportive of their recovery. Additionally, this aspect of care provides an opportunity to dispel a lot of myths related to substance use among their peers. Data shows that although young people are using substances at an alarming rate, they often overestimate how much and how often their peers are using. So, where do we go from here? In reality, it's not about recreating the wheel, and it's not about drastically shifting the way we do our work. It's really just about shifting the lens through which we view our clients and understanding the relationship between mental illness and substance use among our young people. It's about realizing that when an adolescent presents at our organization for one disorder, there's a good chance that the other one is also present, at least to some degree. So what it really comes down to is thinking outside of those silos and really understanding that there shouldn't be silos, except that we work in systems that have created them. For those working in substance abuse facilities, we need to have more conversations about underlying mental health symptoms and how they contribute to substance use. And for those working in mental health facilities, we need to have more conversations about substance use patterns and the effects of substances on mental health. We also need to continue expanding our behavioral health system to include a full continuum of prevention, treatment, and recovery services with an emphasis on integrative care for co-occurring disorders. Providing young people with treatment that addresses both their mental health and substance use also greatly improves outcome. Providing this treatment as early and as soon as possible helps prevent the downstream impacts of substance use like school dropout, teen pregnancy, homelessness, unemployment, and the increase in HIV, hepatitis B and C infections. And I'm sure we can all recognize and appreciate the long-lasting effect of these issues. So during this two-part training opportunity, you're going to be learning more about screening tools like SBIRT, which can quickly assess the severity of someone's substance use and provide a brief intervention to help them raise awareness and insight about their substance use, and also provide a referral to treatment if warranted. You're also going to hear about motivational interviewing and evidence-based intervention that can really assist with enhancing motivation for change. And for those of you who may know me, you know I'm a very big fan of motivational interviewing because I found it to be one of the most effective interventions for individuals with a substance use disorder, particularly those who we would identify as being pre-contemplative or contemplative about change. And this definitely includes a lot of adolescents and young people. Ambivalence is really part of the adolescent process. So you're also going to hear more about the resources available to you in Bucks County to assist adolescents and their family who may be dealing with co-occurring issues. So again, thank you all for participating and for offering this training because I think it's full of information that you're going to find useful. I also want to conclude by saying thank you to each and every one of you for the very important work you do. You may not realize it, but the work you do has a profound and lasting impact, not only on the young people you serve, but on their families and their communities. I'm sure that the information and the tools provided to you in this two-part series will be really valuable as you continue your work with the youth of Bucks County. And I thank you again for including me. I thank you for all you do, and I thank you for being a catalyst for change.
Thank you so much, Sandy. We really appreciate the speech today. It's wonderful. We're going to take just a short break before we pass it over to Dave. So if you can come back at 9:45, that would be great.
Hi, everyone. Thanks so much for coming back from the break. I wanted to hand it over now to our trainer today, Dave Fialco. Dave is an internationally certified prevention specialist and a nationally certified tobacco treatment specialist. Dave has over 19 years experience working in the drug and alcohol and mental health fields, working in treatment, prevention, tobacco cessation, and enforcement. Dave is employed by the Council of Southeast Pennsylvania as a prevention specialist. I'm going to hand it over to you, Dave. Thank you.
Great. I was looking for the mute button. Thanks so much, Leigh. Thank you, everybody, for making it today. No pressure to follow up Sandy. Sandy's an amazing speaker. She's a tough one to follow, and I just think she identified so many key things, the dual diagnosis to co-occurring language change over the years, viewing individuals as multidimensional, the ACEs study. If you haven't checked that out, please do. There's a video out there, Nadine Burke. I think she's the Surgeon General of California now. Amazing details on trauma and links to substance use, and then I really liked Sandy's discussion about shifting the focus or the lenses, I believe she said, between mental health and drug and alcohol. So yeah, great segue. I hope I can satisfy everybody's expectations of the things that Sandy identified and translate it into effective screening and how we can do this. And so just a little bit about me. I got my start in the field with mental health. So I worked at a partial hospital for schizoaffective schizophrenic disorders and learned an incredible amount after only working in the field for about a year, during an internship during my undergraduate and saw that what we called back then dual diagnosis, and got interested in providing the DNA aspect. And that's how I found my way through counseling for, mental health, the ATOD, now in the world of prevention for the last 13 or 14 years, I guess. And so, that's a little bit of that segue. All right, so I wouldn't be able to be here without funding from our single county authority here in Bucks County. Thank you so much, Bucks County Drug and Alcohol Commission, for funding the time. They fund all of our SBIRT, or Screening, Brief Intervention, Referral for Treatment efforts that we provide here in Bucks County. If you haven't been to their website, it is really a one-stop shop. I highly encourage you to click on the links when you get these slides. You will be receiving a PDF version of this slide deck, and I insert a lot of active hyperlinks. So if it's in green, you click on it in the PDF and it'll bring you there. So I really encourage everybody to use the handout, use the slide deck as a resource. But check out their website. It's a phenomenal resource for Bucks County. And hopefully upon completion of this webinar, and you'll have the second part with Anita Kelly next week, but upon the completion of this one, you'll be better able to identify three major components of SBIRT: the screening, the brief intervention, and if needed, referral for treatment. We'll be able to better define the craft and fully understand it and utilize it and implement it, and do so by conducting a screening. You'll be able to identify three main principles of MI, or motivational interviewing. You'll be more familiar with FRAMES, one of the many acronyms we'll be talking about today, as well as ORS. And then you will fine tune or possibly develop, if this is your first time, the ability to effectively intervene with those who are at a moderate or high risk for psychosocial or healthcare problems related to their substance use or misuse or possibly abuse. You'll be able to utilize the knowledge base of the field of addiction by discussing features of substance use disorders, maybe understand them a little better, and then demonstrate the knowledge. And hopefully you'll be able to stomach a ridiculously large number of acronyms without question and pretend that you fully understand them, because there are a lot of acronyms in this field. Just with a little humor there, we will be able to connect the dots when we see these acronyms in the future. And why SBIRT? Why screening brief intervention for TAY's population? Well, looking at the 2020 National Survey on Drug and Use and Health estimated that among people aged 12 or older in 2020, 58.7%, almost 162 million people. And the last time I checked, we were around like 335 million in the USA, used tobacco, alcohol, or an illicit drug in the past month. That's age 12 and older, all right? And what we're seeing with all of these is the majority of those ages are between 18 and 25, right? 22% of those people were binge alcohol users in the past month. 4 or more drinks in one setting for a female, 5 or more drinks in one sitting for a male. That's binge drinking. What constitutes a drink? 1 shot of hard alcohol, 1.5 ounce, 5-ounce glass of wine, or a 12-ounce, 3.5% beer, right? So understand what those all are. Marijuana was the most commonly used illicit drug. It is still illicit federally, and it is still illicit here in Pennsylvania, even though it's been passed for recreational in surrounding states. And it is no surprise that it is the most common used illicit drug. Many of us in the field see it as, as just the individuals who are partaking view it with a very, very, very low perceived level of harm. And amongst that, again, the highest use age were 18 to 25. So when you look at that, 18 to 25, the 18 to 21, you're still, that's 3 years where you're still not supposed to be using it. It's still illegal to use, even if it was adult use legal in the state. So just that, the whole perception of harm, we really need to bump it up a little. Among people aged 12 and older in 2020, 1.3 million people initiated cigarette smoking in the past year. All right. And so we're expecting these to increase, post-COVID. We'll see an increase, and TAY's Pennsylvania Youth Survey should be released any minute. I know the Epicenter already has the data. I just checked their website yesterday morning. It has not been released, but if you're not familiar with the Pennsylvania Youth Survey, great resource. So what is the acronym of SBIRT? Really, screening, brief intervention, referral for treatment. It's 3 parts. It's an evidence-based practice used to identify, reduce, and prevent problematic use, abuse, dependence on alcohol, nicotine, and other drugs. All right. It's easy. It can be done annually. It can be done biannually. It can be done, every other month. If you're meeting with somebody once a month and they are, somebody who is an at-risk population of using, is there any reason why you can't give them the craft every time? No, there's not. But it is easy to use in an annual screen when you might just only see somebody once a year. It can be done both interview style or self-report. All of them are reviewed by professionals, healthcare professionals. You don't have to be a doctor. You don't have to be a licensed clinical social worker to review this. Any healthcare worker can use these. One of the things that we always encourage are going to be individuals like CRSs who may have, a unique role in this. And it is streamlined. It's an existing structure that can be utilized and slipped into your current policy and your current structure at your organizations. And why SBIRT for adolescents? And what are some of the challenges with that? Well, we're going to see that adolescents are often hesitant to report substance use. We are going to see that substance use abuse is often normalized amongst adolescent age populations. As Sandy mentioned about pre-contemplation and contemplation of the stages of change, most adolescents are going to be in that stage. They don't see a problem with it. They haven't seen the impacts. They only see the good or the perceived good. And the fear of, they're also fearful of some of the impeding opportunities that they're looking forward to in life, such as college, employment, JP, justice, the legal system involvement, and parental involvement. They don't want their parents to find out for many different reasons. So they're not always upfront. A lot of times the young people will be referred, and they'll report, well, it was only really a one-time thing. I don't do it very often. And you have to meet them where they're at. And that's why having this tool regularly allows for that young person, that adolescent, to kind of come to be a little more honest about their use if they're given multiple opportunities. Just don't give it once and shelf it. You can use it again in another month or two and see if anything has changed with them, where they might be more willing to disclose some of that information. This allows for self-reflection, regarding the use of ATOD. If you give it to them every so often at increments, every other month or whatnot, they're going to possibly think about it a little more. But either way, once you provide the screening tool, it can empower them to identify and explore other ways and alternatives to having fun. As Sandy mentioned, that dopamine, that brain is molding and discovering what gives them dopamine. And if all they're doing is, sitting around and hanging out, engaging in low skill, low effort things that result in high amounts of dopamine, such as using marijuana or alcohol or nicotine, they're less likely to try things that require skill and effort. So we really want them to become more empowered and explore what they're capable of. And it results in affirmation, from not only us, if they report 1 month, hey, yeah, I actually thought about that. And I actually started shooting hoops with a few friends, in the afternoon down the street. And I noticed that, I'm using less nicotine or marijuana or alcohol now. And I've been getting, a little more recognition for that from my friends. They also, you can also give them that whole adult or parental positive affirmation for those healthy behaviors. It can, providing guidance resources if a change is needed further. So giving them brochures, pamphlets, a little bit of information, what Sandy mentioned, psychoeducation, to reinforce the prevention messages that we all want to get out there, increasing the perceived level of harm. So this is just, one of the many reasons for providing SBIRT for TAYs. And if you're like me, you'd like to see the data, where's the data that actually shows that this works? There was a recent study that looked at youth ages 14 to 20 who received an alcohol brief intervention in emergency room settings. And following the brief intervention, 26% had reduced alcohol use to non-risky levels at the 3-month check. All right. So it also resulted in brief intervention, resulted in greater readiness to change, was positively related to the brief intervention response, as well as greater alcohol use at baseline was negatively related to brief intervention response. So this brief intervention works. It's just planting the seed. It's giving that, allowing that young person through motivational interviewing to identify what they may want to try differently, all right, and other options. that will work. And that active link there will take you to that study, and you can kind of read a little more of it. But what we do know through studies, lots of them, this one particular is looks at as individuals continue to mature between 13 and 21 years old, the likelihood of lifetime substance abuse and dependence drops 4 to 5% for each year that initiation of substance use is delayed. So if that's huge, that's a 45% reduction in the likelihood of attaining a substance use disorder in their adult years, if they're just simply able to wait till they're 21 to start to experiment. And so when we're looking at that, when we're providing these screenings and the young person is coming back as no risk or low risk, make sure we give that positive recognition. Great job, keep it up. Just so you know, this is what you have to look forward to if you continue to choose to avoid substance use, and give them that psychoeducation to help reinforce them to continue those pro-social healthy behaviors. But it pays off, right? And then what we're looking at really is through adolescence, incredibly difficult time of life to navigate. I think back to my adolescence. I was a relatively middle of the road kind of guy, but I'm pretty sure if there is such a thing as guardian angels, there were some probably episodes that guardian angel needed to seek some PTSD treatment for it, because us as adolescents can push the boundaries quite a bit. So when we're looking at how's that substance use progression look? It starts with abstinence, right? And when we're looking at some of these biopsychosocial assessments of individuals coming in for treatment, and we're doing that initial interview, we're finding that young people are reporting tobacco use, marijuana use, first alcohol use at ages of 10, if not younger in some cases. But it starts with abstinence, which turns to experimental use, which turns for some into non-problematic use, where they're using it occasionally, experimentally, a little more than experimental now. They tried it, they had a positive reaction to it, now they use it occasionally, and they're not seeing any negative outcomes from it yet. They haven't been caught by their parents, they haven't been caught by the school policies and procedures that are put in place. They haven't had any negative interactions with peers or friends or law enforcement. So to them, it's non-problematic use. Is it problematic when we're looking at brain development? Yes. But is it non-problematic to them? Yes, it is. And once problematic use arises, that's where, for many young people, they kind of say, okay, hey, I learned my lesson, I'm good. Maybe not next time. Thank you very much. There may be still occasional use somewhere in that future, but for many people, once that problematic use pops up, that's good enough. Now, for others, that continued use despite that problematic use, that turns into abuse. A loss of control over time turns into dependence, and hopefully maybe somebody provides them with a screening, whether it be at their annual well visit, at their medical doctor visit, family doctor, or maybe they're seeking mental health services for something else, and somebody provides them with a screening for substance use disorders or substance use, and they're like, oh wow, hey, here's an avenue for some supports and some recovery guidance and some treatment. They take it, and guess what? They can enter secondary abstinence. And for many adolescents, that's wonderful, because if they identify that early on, that brain is so malleable, and it can heal, it can reform, undo those connections, those neural connections, and reform them with healthy pro-social things. So substance use progression is not a death sentence. It can end up where you start, which is abstinence, if we utilize things like screening tools. And the SBIRT model of continuum response, we look at it with three things, all right? We look at it at primary prevention, we look at it at brief intervention, and we look at it referral for treatment. A lot of the things that we do from day to day fall in that primary prevention or recognition for responsible use or abstinence. And we're looking at it as a continuum through this abstinence, through substance use disorder. Obviously, it's going to look different between adolescent and adult populations. For adult populations, this is where we live. This is where many of us live. This is where individuals can use substances responsibly, whether that's alcohol, nicotine, supposedly, and now cannabis or marijuana is viewed as it can be used responsible by adults. But only adults who have fully formed brains. And as Sandy pointed out, we're seeing now that this brain is not fully developed, especially the prefrontal cortex, until 30, right? Up to 30. But if you're 21 and older, this is the theoretical model. Abstinence, experimental use, and social use. What that means is you do not exceed, when you go out for drinks with your friends, you do not exceed that 4-drink limit per sitting if you're a female, or 5-drink limit for males. And if you do that, you never bring your blood alcohol content above 0.08, legally drunk, right? Or legally impaired. And more than likely you avoid any negative outcomes associated with that. All right. If you exceed that limit, you now fall into the binge use, which is binge drinking, or substance use if you're using substances, which can lead to that abuse, which can lead to a substance use disorder, which we want to keep people out of, right? That's the whole idea with SBIRT. SBIRT's main goal is to prevent this segue, this yellow section here. This is the segue to substance abuse or substance use disorders, is that binge use or abuse. If we can eliminate that, we cut off the bridge to substance use disorder. If we can just positively reinforce individuals to stay in that green, then we're doing SBIRT, we're utilizing it, we're making it effective. But obviously this is for adults, right? This is what it looks like for adolescents. Abstinence, and you see it kind of goes over in experimental use, because apparently 75% of youth have, tried alcohol, nicotine, or marijuana by the time they graduate high school, which is an incredibly large number. But for the percentage of the people who chose not to use, right? The number one reason was parental approval or disapproval, depending on how you look at it. So that whole thing that Sandy was saying about like families and the importance of having parents involved, very important part of this puzzle. So abstinence, and that, yeah, I tried, I took a puff off a friend's vape, 3 months ago, and I didn't like it. That's what that is, right? And when we look at where we want to keep youth out of, we want to keep them out of social use, binge use, abuse, and substance use disorder. Because those things, that adolescent brain is just so primed to pick up on the dopaminic response, that dopamine response, in such an effective way that it really can hinder the ability of that youth to make sound decisions. So if we can cut out this experimental use and social use during those formative years, what we all know as the critical period between ages 12 and 21, we're going to see far better outcomes, all right, with and hopefully a reduction in the number of adults reporting, meeting the criteria for a substance use disorder. So this is kind of how this continuum looks. This is, again, active link, so you can read more about this. As Sandy mentioned, the brain develops from the back to the front, with the prefrontal cortex being the last part to develop, which is the decision-making part of the brain. So we really need to reinforce and have as many opportunities for that young person to ask the question, to be exposed to healthy resources and options for use, for not using. When we look at stages of change amongst adolescent age, the majority adolescent populations are going to be in pre-contemplation or contemplation. And so what we're really going to want to look at is enhancing the youth's motivation by raising doubt about their current behavior. We want to increase their perceived risk or perceived harm of the things that they're doing. And right now, it's incredibly challenging. We have young people, claiming, that, marijuana is a plant, it's not a drug. And they're hearing this from the top down. We're hearing this from, politicians, from movie stars, from influencers, individuals who should be responsible in their messaging. Yet every day I hear an adult, somebody in an influencing position, say things like, weed isn't a drug, it's a plant. And this is what adolescents hear. And it decreases their perceived level of harm and increases the likelihood that they're going to try it. So we really have to change their mindset. And this is where SBIRT comes into play. If we can have a meaningful dialogue, a 5, 10, 15-minute discussion about their current use, it could change their life profoundly. So we change our mindset and we end up with a different end result or changed result. So if they're in pre-contemplation, we want to get them into contemplation. If they're into contemplation, we want to get them into that preparation or action stage. So it's always just kind of trying to get them to the next stage. All right. And you can learn more about this. Anita will be talking about this next week, the SAMHSA SBIRT pathway. So I'm not going to go too much into this because I don't want to, be repetitive or cover things that Anita is going to cover. So we'll see the SAMHSA SBIRT pathway next week. But this is an algorithm which is similar to the pathway. And this is just kind of how SBIRT works when we're providing a screening form for a young person. We ask that simple pre-screening question. With this craft, it's the first 3 questions of the screening tool. If it turns to positive, then there's more screening tool questions that will allow you to kind of gain a little more information regarding their current substance use. And depending on how they score, you either positively reinforce the positive behavior or you briefly intervene, providing them with a little psychoeducation and motivational interviewing and exploring alternatives to their current use. And if it's a high score, you can again do that motivational interviewing and provide them resources and help them identify alternatives. But you also will want to consider referring to treatment. So what does a brief intervention really look like? We want to keep it simple. SBIRT again is a 3-step algorithm. It can be 3 to 5 minutes, or it can take up to 15, depending on how it goes. Depending on what that youth identifies. No current use, great. Positively reinforce and identify the benefits of it. Of not using any substances. That's the 3 to 5 minute version. The 15-minute is going to be if that individual reports regular use or intermittent use of substances. And which time we're going to provide the education about their current use and the potential risks of their current use pattern. And we want to match the individual stage of change to our style. So we don't want to argue, we don't want to push, we don't want to drag. We want to approach this from a health education promotion standpoint. All right. We just want to provide and support. We don't want to belittle or force. The goals again are, increase awareness of potential problems, or educate the individual, reduce the risk of harm, assess how the individual thinks and feels about self in relation to substance use. And this will come into play when you're providing motivational interviewing, when you're asking questions like, well, I'd like to hear a little more about that. Can you tell me a little more about that situation, which will allow them to kind of identify some feelings and thoughts that they may not have thought about prior, which would then increase their internal motivation for change, or maybe start identifying some reasons for internal motivation. You know, if they're ambivalent, we can identify and address and work through that. Help make decisions regarding changing current use. You can assist them, ask them what you think would work for them. And when when you're asking them, you know, do you think we could do this by the next time we meet? Set realistic goals that allow experience of success. We want, you know, these baby steps, attainable goals for that individual. We don't want to set the bar too high and have them fail. You know, well, either way it goes, we'll develop that plan of action to support that decision and help support ongoing action. So we do this by frames. Frames is one of the acronyms that you'll hear. And frames is broken down into feedback, how their use may impact their current and future health. All right, when we give them the scores of the screening, and we're going over as far as low risk, moderate risk, high risk, and we're placing that responsibility on them to change their behavior. We're giving advice based on specific concern and the menu or the variety of options for change. Will be identified through that motivational interviewing process, through them identifying what else they could do differently. And that empathy is very important. We want to be empathetic. We don't want to, you know, force or drag, as mentioned, and we want to make sure we keep a positive attitude. And then self-efficacy. We want to reinforce the patient's belief in their own ability to change. So looking at these broken down in a little more detail, we're going to provide constructive, you know, non-confrontational feedback about an individual's degree and type of substance use based on information from the screening form that they're completing. And we want to acknowledge the individual's risky behavior. We want to, you know, not make them feel bad about it, but let them know that you have a concern. So you can say things, you know, like, well, I am concerned about, you know, your reported use of cannabis. All right. And so you're going to review the results of the screening prior, and you'll discuss personal risks associated with the current substance use patterns. You'll provide general information about substance-related risks and harms, pros and the cons. You know, is one of the things that, you know, often is in discussion. I hear that you like, you know, having a few drinks with your friends, but what are your concerns about those, right? And then we'll link the individual presenting a complaint to his or her substance use when applicable. So, you know, when they identify some of the cons, we can link it back to their report, and we'll compare individual substance use patterns and problems to similar people in the population. You know, where you can use learned experiences. So if you want to learn more about the frames, again, this is going to be a video that will be hyperlinked. You can click on this at the bottom there and watch a video of it. These are all live. And again, I encourage you to take a look at those. But when we're looking at responsibility, you know, this is the responsibilities on the person. It's not our responsibility as an individual to make change for somebody. It's going to be their responsibility. And that individual should have an active, rather than a passive role in changing his or her behavior or pattern of substance use. That responsibility will hopefully enable this individual to retain personal control over his or her behavior and its consequences. And when we're doing this, when we're really putting the responsibility on them, we want to ask for permission to talk about their substance use. I'd like to talk about, would you be willing to discuss more? And we don't want to impose our personal views or goals on the individual, but we want to be open and non-judgmental. You can say, I am concerned, but you don't want to say things like, well, if you continue down this pathway, you're going to end up moving to harder drugs. It's not always the case for individuals, so we don't want to impose our personal views. We do want to acknowledge that the individual, again, is responsible for his or her own behavior. And we want to restate and reaffirm the individual's choice of continuing or changing the behavior. Sometimes I guess we can look at it as harm reduction. Sometimes we're not going to get a person to stop altogether. But if we can at least get it going in the right direction, then we can reinforce that direction change. We can always ask them to make sure that we're hearing it correctly. So you decided to reduce a little, instead of drinking 4 or more beers next time you go out with your friends, you're going to drink less than that. Is that what I'm hearing from you? Is that right? And they may say yes. All right. So that's harm reduction. So they've now moved from binge drinking to non-binge drinking. Would it be ideal if they weren't drinking underage and as an adolescent? Yes. But again, those attainable baby steps that will help promote success in that person. That's what is going to make change so important. When we look at giving advice, we want to ask for permission. All right, is this is something that concerns me? Would it be okay if I shared my concerns with you? We want to preface advice with permission to disagree. You don't have to agree with me, but this is what I am concerned about, and this may or may not be helpful to you. Plant that seed, right? We want to integrate our own individual concerns with using information that they provided. And sometimes they might identify that their drinking might be interfering with things like other treatment or friendships or other feelings that they're experiencing. So something along the lines of, I wonder if your alcohol use might be interfering with your recovery from depression. I know it doesn't always feel like it, but alcohol is a depressant. You don't have to commit to anything, but can we look at other ways you might be able to relax or unwind? And so if you put it in that kind of question format, you're actually encouraging that person to identify their own advice. You're addressing your concern. You're eliciting them to come up with an alternative way. So they're giving themselves their own advice in a way. And as I mentioned previously, I'm concerned is another great introduction way of doing this. I'm concerned that you feel like you need to take more medication than is prescribed to feel better. Do you think we might be able to talk to your doctor about that and see if there's anything that can be done? What that's referring to is sometimes individuals may be abusing, prescription medication more than needed. They're using it as perhaps, abuse or misuse of that medication. If they're mixing medication with illicit drugs or legal drugs that are being used underage, you're taking a lot of medications with lots of different instructions. You know, how about you bring them all in next time? We'll try to figure out a way to make it easier for you. That way you can have that opportunity to discuss things like, you know, well, this medication says right here not to be taken with alcohol. And these are going to be the reasons why you might want to avoid using this in the future, using alcohol in the future. What are your thoughts on that? And that can, you know, allow that person to come up with their own advice. All right. And by that motivational interviewing process, they're going to be able to come up with a menu of options that they've identified that might work for them. Maybe it will be cutting down on use. Maybe it's reducing a harm associated with use. You know, we'll go over the CRAFT screening tool after our 5-minute break, and we'll talk about the importance of identifying things like, have you driven in a car or driven a car after using substances. So that's what we're talking about, reducing harm associated with use. You know, quitting all use. You know, are we going to have somebody who just says, yep, I'm willing to quit. I'm ready to do it right now? You might. And then getting help. All right. Utilizing resources, utilizing, you know, healthy pro-social activity outlets in the neighborhood, whether that's, you know, the YMCA or clubs or intramural sports in school, or, you know, parental involvement, or there might be nothing that needs to be addressed if that person scores low on the screening. A lot of times, you know, if you have these resources, you know, or how would you say, informational brochures available in your office, that's also a great thing to not only reinforce positive behaviors if they're already doing it, but also allow them to, if they are engaging in behaviors that are unhealthy or risky, to explore some of the possible negative outcomes associated with that. And then empathy, right? We want to be empathetic. We want to be able to understand and share the feelings of the other person, the young person who we're interviewing or screening. I always say it, you know, I never forgot what it's like to be that age, but sometimes we lose that empathy of what exactly they're dealing with. And the adolescent population right now has social media, social influencers. They have, you know, expectations. Sandy mentioned sports and, you know, academic success are huge, you know, stressors in, you know, certain socioeconomic brackets. And I see it. I see the pressure there to perform and to fit in. It's incredibly stressful. And what I see now are adolescents are unable to escape this. I think back to my own adolescent years. You went to school. It was stressful for some of us, others not so much. You had social anxiety. You had anxiety to perform academically. You had anxiety to perform physically, whether that was sports or just gym class, whatever it was. But then you left school, and that stress was compartmentalized. The young people today are experiencing non-compartmentalized stress from all different areas. You know, we see 10-year-olds with smartphones who are on all of the, you know, the apps and YouTubes and Twitter and Facebook, and, you know, group texts. Be aware, if you have young children, be aware of group texts, right? Because starting somewhere in that 3rd or 4th grade age group, you'll start to see this. And this is a source of anxiety. This is a sort of stress, that source of stress that really no previous generation has experienced at this. So there is a very difficult path to escape a lot of the stress that adolescents are experiencing, and we have to empathize with that. You know, they are inundated with messaging, with expectations from all angles. So it can't just be as simple as, well, I got through this, you know, I experimented and I dealt with stress when I was growing up and I turned out fine. It no longer applies. So don't try to direct it. Don't try to pretend that you know what they're experiencing, but let the conversation unfold. Let them express, you know, what they're experiencing, what they're feeling through exploration, all right, through asking the question and making sure that, you know, am I hearing you correctly when you say this? And we want to listen attentively, and we don't, again, we want to avoid that authoritative expert tone. We don't want to go there. We don't want to be the telling them what to do. They get enough of that elsewhere. And then self-efficacy. You know, when we look at, you know, the definition of it, we're going to look at as your ability to achieve a goal or complete a task that depends on whether you think you can do it. So we want to build up their confidence level. We want to build up their confidence in their own ability to find solutions to what they're facing. You know, so I hear, this might be an example. So I hear you're feeling stressed every time you check Facebook or Twitter. Do you think there's something else? Do you think there's a way that you can reduce that stress? And that person might, you know, come to the realization that, well, maybe I can check it less. Maybe I'll put a limit on time limit on my phone. Maybe I won't check it during these times of the day. That promotes that self-efficacy. They're the ones who came up with the idea. And if they've already started to implement that, you know, recognize it. If they've had success in the past, reinforce it. All right, promote it. Draw parallels to, you know, whatever it is that you're trying to encourage them to think about, to change their use. If it's substance use, you know, if they've been successful in previous things that haven't had to do with alcohol or tobacco or other drugs, you can draw the parallels. Well, you've been successful in this. Do you think you could apply some of those same things to these efforts? All right, and assure them that they can be successful and that we'll be here to assist. And we'll also want to address the myths, some of the myths associated with the self-efficacy. So a lot of times, you know, these positive changes can be kind of lessened when they hear, you know, counter messaging from outside sources. So you can address those and encourage the discussions. All right. So I think we're a little ahead. So we'll continue on motivational interviewing. I thought we were going to be a little back, so I slid the 5-minute break back, but we'll be just fine here. So utilizing motivational interviewing in this process, along with frames. All right. You know, it was first developed as a brief intervention for the treatment of alcohol problems. Motivational interviewing was, and it is a collaborative, goal-orientated style of conversation. And it uses language of change. It's designed to strengthen our personal motivation and internal motivation and reduce one's ambivalence. You know, it will elicit and encourage exploration of individuals' own readiness to change. And it's simply a conversation that is going to help with this ambivalence. It's most useful when ambivalence is high and people are stuck in mixed feelings about change, and confidence is low, and people doubt their abilities to change. So this can really greatly allow somebody to identify their successes, what's going well, increase their confidence, Motivational interviewing helps when their desire is low. People are uncertain about whether they want to make a change. All right. And it also helps when the importance is low and the benefits of change and disadvantages of the current situation are unclear. The main purpose is to change a behavior of motivational interviewing. It is evidence-based, more than 200 clinical trials, and key elements required for change are going to be importance, ability, and desire. All right. So when we look at it, we want to really have that person identify the importance of change. What's in it for them? What's the buy-in? What is going to allow that person to identify the need, their own desire for change, and which will increase the likelihood that they'll be able to identify their own ability to do so, which will build their confidence. And the more you do that, the desire increases. All right. So importance, ability, and desire. And when we look at motivational interviewing as a whole, right, we have 4 regions. We have motivational interviewing spirit, change talk, principles, and ORs. And when we look at change talk, this is going to be talk that allows for that individual to identify their own reasons, asking a question, listening, reflecting back on them. Am I hearing you correctly? Is this important? So these are going to be the 4 principles of this. So I wanted to save some time on both areas for conversation and question. I think we'll save the motivational interviewing for the second half. So I would like to open it up at this time for some Q&A and comments. And the way we can do this is we can, let's see here, where's chat? We can do it in chat, or we can, I don't see the Q&A. Why don't we just do it in chat? If there are any questions, we can address them right now for what we've talked about so far. I have 10:40, or well, it says 10:37 on this clock here.
We just got a comment here in the chat, Dave. I don't know if you can see it. I can read it too as well.
Wow. Yeah, I see that. I was hoping to hear a bit more about substance use and HIPAA. For example, if a client has significant substance use, that could be seen as a safety risk. Yeah, so one of the things I always, mention during the screening process, especially with youth, since we're all mandated reporters, and when you put in the Health Insurance, Privacy Act as well, is, what's said in here is confidential. I only will share the information if you give me it with your permission, or if I feel that if you are in danger or someone else is in danger. And so I always just give that right up front before we start the discussion. When they answer the screening form, and when I get it and I'm starting to review it, I always give that. So yes, there might be some times where we need to report things, but as long as we preface it with it, I think we're good. And I think I've never had resistance to that. And, there may be youth who this is an opportunity for their voice to be heard. because, as you heard Sandy say, we see an incredibly high number of young people, 10 and older, having suicidal ideations, 10 and older. So that is something that's really hard to wrap our minds around. So this may be an opportunity where if you give them that pretext, that I have to report if, if your safety is in danger, this may be there and this may be there. Well, I can say I thought about killing myself. At which point, of course, you would use that suicidal assessment, the plan, access, as far as to assess the threat. But either way, yeah, that may be a way for them to actually have their voice heard without having to come out and make a separate phone call and schedule an appointment for somebody else. All that can be incredibly intimidating and stressful. Great question. I don't see any other questions coming. There are no bad questions, bad answers. So I feel like if if there's even a comment, maybe there was something that you felt wasn't clear and needed a little more clarification on. Okay. Well,
If there's no other,
I
questions
guess
at
it's
this.
better to be a couple minutes short than not getting everything in.
Yep. So we will take a break, and everyone can come back about 10:50.
All right. So picking up on motivational interviewing and excuse me, and looking at SBIRT, the change talk, the principles, and what we call OARS, another acronym. We'll take a look at that again. Motivational interviewing it really has a spirit associated with every conversation. So we want to make it, keep in mind 3 key elements. Collaboration between yourself and the client. All right, this is a collaborative effort. This is not something that we're telling somebody to do. This is a conversation which we're listening on, and we're checking to make sure we're hearing them correctly, and we're soliciting and evoking or drawing out the client's idea about what their change looks like, if desired, while emphasizing their autonomy and their ability to be successful. Motivational interviewing should communicate compassion, acceptance, partnership. All right, this is a partnership with that person. You're spending the next 15, 20 minutes in a meaningful conversation. We're there to support them, and we want to show that respect by listening. We don't want to be telling them what to do. We want to be listening. We want to be there for them, and we can look at it under a certain rule. All right, so another acronym. We want to resist the writing reflex. We don't want to tell people what to do. That's going to be their job. They're the navigator. We're simply the guide. If we can, we should understand their motivation. All right, what is motivating them to actually make the change or not make a change if they're not willing to do so. And we want to listen. We're going to let the individual tell them what they need. All right, they'll let you know. And we want to, of course, we talked about that self-efficacy. We want to empower the client. All right. So when we're looking at OARS, all right, It's a set of basic communication skills which can help the individual identify internal motivation to change their current behavior. And 4 of the basic concepts that are used in the acronym are going to be open-ended questions. All right. We don't want a simple yes or no questions. We want them to be more descriptive. Tell me more about your use of marijuana. We want to affirm, provide affirmations associated with that. And it can start with just something real simple. Affirmations should be something that is going on. This isn't, has to be done at certain increments. We want to do this throughout the process, and affirmations can start right when they walk in, and sit down for the conversation. I really appreciate you taking the time today to make your appointment. I know it's not easy. Our lives get very, hectic and chaotic from day to day. So I really appreciate you, taking the time to make it today. And then it can be led into the conversation as well. I appreciate you sharing that with me. I know that can be a little intimidating, sharing that personal information. And reflective listening. We want to make sure we're hearing that person correctly. And that is often linked to an emotion or a feeling. And it may be something like, it sounds like you are angry about that. And that will allow that person to say, yeah, I am. And it makes me upset because of this, and they may go on and talk about it in more detail. It's an opportunity for them to have, to bring out more information than we would if we're just asking, a set series of questions. We want to summarize too. We want to make sure that we heard everything. And so I just want to be sure it sounds like, that, you see a need for reducing the amount of marijuana that you smoke or alcohol that you drink because you don't want to experience that same outcome again. And it sounds like you're looking at maybe just reducing the amount that you use over the next month, and avoiding these situations. And am I hearing that correctly? Is there anything I left out? So we want to summarize everything that they said into an opportunity for them to say, oh, well, yeah, that's accurate. You know what? Let's change that. All right. So summarizing allows for them to kind of review what you heard and what you're interpreting and your, reporting to them as far as what they want to do. So increasing their own ability to it. Now, that reflective listening is going into a little more detail. It's relating what the person is saying. I know when I go and hang out with my friends, this may be something this person says, I know when I'm going to hang out with my friends and I'm going to vape because it's always there. Someone is always holding. We've all been friends since grade school. And I don't think I can just stop hanging out with, and honestly, I don't want to stop seeing them. It's not like they're smoking meth. And, you'll see this, justification and kind of them expressing their own feelings. And I see this all the time with young people who are referred through things like student assistance programs. For policy violations for vaping and substance use. And what we actually use with them is something called Teen Intervene, which is an SBIRT program. It's 3 sessions. It starts with a screening, and then it allows for them to engage in the motivational interviewing process over the remaining 2 sessions. And then we actually bring their parents in too, if they're able to. So what I hear with these young people, though, are just this. It's kind of, they know it's going to be there. It's always there, especially with these vape devices. Somebody is always holding. All right. So, a response may be, so it sounds like you feel upset about it always being there. Yeah, yeah, I guess so. Well, can you tell me some more about that? All right. And so, that's really what we're looking at. And your response to something like that is going to be incorporating this ORS, this open feelings about and thought. Thanks for sharing and being honest. It sounds like that's the opening. Your friends really mean a lot to you. That's associating the feeling with what they shared. Since you are willing to potentially jeopardize your own, really mean a lot to you, since you're willing to potentially jeopardize your own health in order to hang out. That's the about because. All right. And then closing with that thought, do you think there is a way you could get them to consider quitting or reducing the amount they vape? And so you're putting the question on them. Is there something that they can do? That are you promoting that self-efficacy? One of the tools, that you can always use when we're using motivational interviewing is the readiness ruler. And this is really vital in helping someone identify whether or not they're ready to change or where they are ready to change. And sometimes the person may report that, they're a 1 or they're a 2. Other times they may be a 7 or a 9. Other times they might be a 5. Everybody's going to be different. And when you present this, we can look at it as, well, you've identified, that you are concerned with the amount of vaping that's going on, and you find it difficult because every time you go somewhere, you just expect it to be there. And your friends always have it. If you were to stop vaping today or this week, where would you be on this scale, with a 0 being not ready to change at all and a 10 being ready to change? And that person might point as, maybe a 2 or a 3. And that's when, that person is saying that, hey, they're actually willing to change. And even though in the red it says not ready to change, a 2 or a 3 or a 1 is better than a 0. So there is some readiness to change. And when we look at that, you don't want to say, oh, wow, you're only a 2. How do we get you to a 4 or 5? No, we want to look at it and be like, oh, well, hey, you said you're a 3. That's great. Let me ask you, what makes you a 2 or a 3 and not a 0? And that's where this meaningful dialogue is going to come to place. That young person might say, well, every time I vape, my throat is sore. I always increase my stress because I'm worried about getting caught. My parents will ground me. I know the school will, reprimand me. So I guess that's why I'm a 2 and not a 0. Okay, great. Well, how do you think, what would need to happen for you to get to a 3 or a 4? I don't know. I guess maybe I need to, just avoid those situations more and see that I don't need to do it. Who knows? Whatever their question, whatever their response is, you're going to help them explore how they can get to be a 3 or a 4. So just the fact that they're low on the scale doesn't necessarily mean that they are that they're not ready to change. It just means that it's not at the forefront. So the whole job is to get them into a higher level. We want to avoid misguided motivation. All right. And that means that when we don't want to put what we think will motivate them onto somebody else, because it's not always going to be the same. Everybody's going to have a different reason for changing their readiness to change. But maybe you can help that person figure it out, what will motivate them. A lot of times with working with youth, we see youth who once enjoyed something, something that they were passionate about. I see a lot of times young people who report, feeling sad or ashamed with where they currently are, and that they used to have something that was meaningful to them, whether it's sports or hobby or interests. And so you could engage them in that conversation. Well, you shared with me that you used to play softball or baseball in the past. Can I ask you why you don't play that anymore? And they may come right out and say something like, well, my current friends don't really play sports, or I just stopped playing before the pandemic, and I haven't gotten back into it. That's actually something that I hear quite a bit now. Young people who were engaged in hobbies and sports before the pandemic, they went a year and a half without engaging in activities that were once meaningful to them. They were isolated for a year. And they discovered that things like nicotine and possibly alcohol or cannabis resulted in that dopogenic response, that dopamine, that improved mode. And they began adopting antisocial, unhealthy behaviors to get that dopamine and to cope with stress and anxiety. So having that conversation with them, what might they can reconnect with to motivate them is really important. So if we can talk them into change through persuasion, they're on their own, we're going to do a lot better job. So help them identify the reasons why they want to re-engage with that sport or activity. Help them through motivational interviewing, identify the feelings that were associated with it. All right. So we don't want to say, well, you're going to get into college and get a scholarship if you re-engage with that sport. No, it just might be for them, it was meaningful. All right. So let's take a look at screening tools and implementing them. And for transition age youth age group, if referral to treatment is needed for a minor, that fear of disclosure prevents some minors from seeking health services because they're afraid that their parents are going to find out. They're afraid of the consequences. But when young people are assured that their providers will maintain their confidentiality, they're more likely to seek care. And this is probably that HIPAA question. How do you deal with that? It's more or less, giving that, that upfrontness, that disclosure. If, I am concerned about you harming yourself or others, then, I'm going to have to, disclose confidentiality. But we can still give them, disclosure and confidentiality rights. The federal law states that if the treatment program or health service facility receives any federal assistance, which most facilities do, the clinician may not disclose information concerning the treatment or care of the minor without the minor's written consent. All right, so even though that they're a minor, they still have rights to where you can not disclose certain things. All right, and if the program or facility does not receive any federal assistance, the question of parental notification is governed by the Pennsylvania law, which permits but does not obligate the clinician to inform the minor's parents or legal guardian about the minor's treatment. So what that means is them going into a drug and alcohol treatment facility. All right, and if a parent is involved, it's often helpful and increases success and actually increases successful completion of the treatment because they have that parental support. Now, that's not going to be the case for all families. Sometimes there's abuse or unhealthy relations in that home life. But if it is that setting which the parents could be a benefit, then in that setting it's often looked at as an addition to successful completion. We want to consider safety, and you can have that safety conversation of motivational interviewing, with that young person. What are the benefits of having one of your parents aware of this? Do you think it's right for you? And if you're unsure, you always can check with your supervisor. That's what they're there for, to help you guide in these situations that you may not be unsure of. Some of the screening tools that you'll see are going to be the one we're going to be really focusing on today is the CRAFT, but you'll also see the S2BI, which is a 7-item tool. You'll see the DAST-10. You'll see the Audit C. The DAST-10 is a drug abuse screening tool. The Audit C is a short 3-question screening tool about alcohol use, and the full audit is 10 questions, alcohol use screening tool. And then you'll see the CAGE. And a lot of people use the CAGE currently, which is fine, but with adolescent age, we encourage the use of CRAFT, because really when we're looking at the CRAFT, some of the language may not be the designed for what we're trying to accomplish with minor populations or underage populations. And the acronym of CAGE is tried to cut down or change your patterns of drinking, been annoyed or angry because of others' concern about your drinking or drug use, felt guilty about the consequences of your drinking or drug use, and had a drink or used a drug in the morning as an eye opener. So some of the language is not always going to be the most conducive for young populations, especially that eye opener one. It kind of normalizes some of the behaviors in the language. And so, can you continue to use the CAGE? Sure. Would you want to utilize the CRAFT and put that into the mix of tools at your disposal? I would absolutely say yes. And then there's some other ones, the SSI and the RAPS-4 questions. The RAPS-4 is a 4-item instrument that provides high sensitivity and specificity across gender and ethnic groups among adults. All right, so this one is not going to be one that you'll want to use with adolescent populations. And then the SSI, it's pretty difficult to score. It is a little bit of a time-consuming screening tool, even though its term is simple screening tool. It's not that simple. So looking at that CAGE again, right? That CAGE, the phrase may normalize ATOD use amongst adolescents, try to cut down or change your pattern of drinking or drug use. I mentioned earlier that yes, this SBIRT is a form of harm reduction, but our real goal for adolescents is for them to stop use. That's really, what is the most healthy possible outcome for a young person who's currently using, is to stop all use, especially when you look at that percentage of decreasing every year that a young person doesn't use substances, decreasing the likelihood of an adult substance use disorder in their adult years by 45%. If they make it between the ages of 12 and 21 without any substance use, they've cut the chance in half. So when we're using things like tried to cut down or change your pattern of drinking or drug use, may normalize it. Eye-opener, again, normalizing that that language or that behavior. But as I said, if you're currently using a cage or a similar question, you don't need to stop using. The craft would more than likely be more effective. The audit C, is this ideal for adolescent age? When we're looking at the audit C, this is that 3-question alcohol screen that can help identify persons who are hazardous drinkers or have active alcohol use disorders, including alcohol abuse or dependency. But just that definition right there, hazardous drinkers, any youth who's drinking that's hazardous. They put themselves in harm's way in multiple ways. Legal involvement, accidental injuries, which are high up there for young people who use alcohol, getting in a car with somebody. So there is no non-hazardous drinking for adolescent age, for minors under 21. And so these first 3 questions, how often do you have a drink containing alcohol? If you were to use it for minors and they marked never, then boom, you're done, right? That's it. But if they go on to answer some of these other questions, they may not fully understand what they are. All right. So how many standard drinks containing alcohol do you have on a typical day? They're not going to recognize what a standardized drink is. A lot of the screening forms, especially the audit, does have on the top explaining what a standard drink is, which is a 1.5 ounce of alcohol, hard liquor. It's a 5 ounce glass of wine, a 7 ounce malt liquor, or a 12 ounce beer that is 3.5% to 5% alcohol content. So that's what we're talking about standard drinks. But again, then that's really complicating things with the teenage and adolescent population. You're having to explain this. And then how often do you have 6 or more drinks on one occasion? That's binge drinking right there. It doesn't delineate between male and female on the screening form. It just has it as 6. So, again, and what we look at is binge drinking for adults, that 4 drinks or more for females in one sitting and 5 or more in one sitting for males. It actually goes down a drink for adolescent or minor populations. So if you're 16, binge drinking is 3 or more drinks in one sitting for females and 4 or more drinks in one sitting for males. So again, this isn't really a tool designed for young people. So if they do answer any of those other 2 questions, the scoring of this audit C, a score of 4 or more is considered positive, and you would go on for the full audit. In women, a score of 3 or more is considered positive, and you would go on to the full audit. All right. So, when we're looking at, question 2 for a full audit, if it was a minor, underage drinkers ages 12 to 20 typically consume 4 to 5 drinks per episode. All right. So when minors are drinking, they tend not to use restraint. So again, that's another reason why the audit is not an effective tool for this, because many of them are going to, fall into this high risk category. It's not designed for them. Many adults can go out and have 1 drink. Many adults go out and have 1 glass of wine with dinner. But what we're seeing that with underage drinkers, they typically have multiple, nearly double the average of the 2 to 3 drinks usually consumed by adults. All right. So all of these screening forms are going to be in interview versions as well as self-report versions. All right. So this may be provided in the waiting room, if it's a self-report version. So if you could imagine, a young person filling this out alone in a waiting room, maybe a 16 or 17-year-old, filling this out, and you read some of the questions here. How many drinks containing alcohol do you have a typical day when you're drinking? How often do you have 6 or more drinks on one occasion? How often during the last year have you found you were not able to? So these are some really deep questions that could potentially trigger a young person in the waiting room, right? And so a little too much information for a self-report version. Now, with that said, in years past, we used to go onto college campuses, and we still do when we have occasion and when we have the opportunity. We haven't had that opportunity in the last 2 years due to COVID, and we'll provide these audit drinking screening forms to college age youth, typically 18, 19, 20, 21, and that's more appropriate for college age. And a lot of these were done at like health fair settings where we would set up a table with like a bowl of candy, and young people come over, and like 18, 19-year-olds, and they'll be, oh, I want to grab some candy. You'd be like, well, the candy's free, but you just have to fill this out real quick. What we're doing is we're assessing whether or not you're using alcohol responsibly, and that young person will fill it out. And what I've seen, again, with this not being the perfect form, but it works, is that they'll actually become competitive. Sometimes they'll have a friend come over and say, what are you doing? Oh, I'm filling out this screening tool or this alcohol assessment, alcohol questionnaire. And their friend will be, oh, can I take one? And they'll be like peeking over each other's shoulder. And there's actually kind of like a badge of courage that starts to come through to where, oh, that's all you drink? Well, I drink this amount. And it becomes kind of like this competitive thing, which again, so this isn't really ideal for that age group, but it does allow in those settings for us to kind of have a meaningful conversation with those young people. It'll often go, okay, well, you actually scored in moderate risk, and I'll explain why they're moderate risk, and then I'll give them some brochures and encourage them to consider cutting down. I'm not going to motivationally interview them at a health fair because it's in a public setting. This is more or less just giving them their score, recommendation, and resources. And all of them get, if they're in a moderate or high risk, they get a treatment locator card that they could always call for help. So in that setting, these might be appropriate. And then scoring and interpreting the audit, again, we're looking at men and women. We're not looking at scoring on adolescent age here. So looking at what is low risk for adults is not going to be low risk for a minor. All right. Risky for an adult is not going to be just risky for a minor. It's going to be high risk. All right. So that's why we don't encourage using the audit for minors and populations. The DAST is more of a specific going to focus on illicit drugs, right? Drugs that are used other than for medicinal reasons. All right, so could you give this to an adolescent? Could you give this to a minor? Yes, you could. But again, it might be too much information. And, so when we're looking at these populations, we want something that's streamlined. We want something that's going to, be one tool covering it all. And we don't have all of this, one for alcohol, one for drugs. And some of these questions on here are going to be, going to be, how would you say, possibly opening up a situation that you may not be ready to handle in the limited time that you have on there, especially if there's things like, have you neglected your family because of your use of drugs, which may trigger guilt and remorse feelings. Have you ever experienced withdrawal symptoms when you stop taking drugs, right? So this is a tool that could be used later on once drug use is identified in an initial screening tool for adolescents or minors, but it may not be right to be used as a quick screening tool. And again, scoring the DAST, has, no problems reported, low level, moderate level, substantial level, severe level. Now, these are going to be viewed for adult populations, these outcomes, all right? So the craft, why do we like it? And it's actually 2 F's in there. My apologies. Not sure how that squeaked through. And the acronym CRAFT it's an acronym for CAR, relax, alone, forget, family or friends, and trouble. Though that's why there's actually 2 F's in there. Family and forget, and then family and friends. So when we look at this, it's very streamlined. It's very simple. It's very easy to provide. In the past 12 months, we're only looking at the year, drink more than a few sips of beer, wine, or any drink containing alcohol. That is worded that way because there's a lot of families that may look at it as, oh, hey, it's Christmas, you can sip a wine, it's a special occasion, you can have a sip of my wine, it's rite of passage, it's our historical based on ethnicity or whatever, or religion or whatnot. So we don't want to have zero there, any drink. So we have more than a few sips. Use any marijuana, weed, oil, or hash. The terminology is there. They know what we're talking about. Vaping or in food. Use anything else to get high. Use any tobacco or nicotine. So we've just covered the gamut in that. We have the DAST, we have the audit, and we now even have a question about nicotine use in here. So it's one-stop shop. It's right there. We can just give this and boom. If they answer any of these, then we go on to questions 5 through 10. If they put 0 in all those first 4 questions, you can go ahead and just ask question 5, which is very important. It's a car question. Have you ever ridden in a car driven by someone, including yourself, who was high or had been using alcohol and drugs? And the reason why we ask that is because they may be doing everything that's right, but they may be in a group of people who are, driving around on a Friday night, smoking weed, marijuana, cannabis, and they may know that it's not the best thing to do, but they're not willing to address it right now. Now we're giving them an opportunity to discuss it, right? So the craft is really like all the screening tools that are used for adults condensed and put into one in terminology that isn't going to trigger, that isn't going to normalize. It is very straightforward, all right? And interpreting it, no risks. There's only one no risk for adolescent or minor populations, and that's answering no to all 4 of the first questions. They would be a riding risk if they report riding in a car, and low score, low risk is going to be a score of 0 in the remaining questions, all right? And that's what you're just going to give brief advice, all right? But they are considered that low risk because they reported more than a few sips of alcohol or whatnot, and riding in that car. A craft score of 1 is going to be what's considered medium risk, where brief intervention is going to be utilized. All right, motivational interviewing. And then anything higher than a 2 is going to be considered high risk, where you'd still do the brief intervention and the motivational interviewing, but now you're going to further, you're going to refer for an assessment for that young person, or at least provide them with the resources that they can get an assessment. So this is just what a screening demonstration would look like. All right, let's go ahead. Oh, that's not what I want. Excuse me. I think I need to share my sound. Is that working, Lay? Okay. So I see that you filled out our alcohol and drug questionnaire. Thank you for doing that. Is it okay if we review that?
Yeah, I guess so.
All right. Just so you're aware, what we talk about in here is confidential. All right? I only tell your parents about what we say if you give permission, or if I have concerns, or if I become worried about a danger to you or someone else. Does that make sense?
Yeah.
All right, great. So let's take a look. So I see here that you've marked that you sometimes use marijuana, and that you marked you have used marijuana to relax, feel better about yourself, or fit in. Do you mind telling me a little bit more about your marijuana use?
Well, I guess so. It's not a big deal. Sometimes, me and my friends will smoke when we're at a party, or really just kind of hanging out on the weekends together.
Okay, so you smoke a little with friends at parties or whenever you're hanging out on weekends. How long have you been doing that?
Probably for the last year or so.
Okay, great. All right, so I see here you marked 12 as the number of times this past year. Am I correct in assuming that's about once a month or so?
Yeah, maybe sometimes twice a month. I don't really see a big deal with it. I think it's safer than alcohol. My parents would also agree with that.
Okay. I'm curious. What do you like about marijuana?
Yeah, what do I like about it?
Yeah.
I don't know. It's just kind of fun to do with my friends. It lets us relax after a long week at school. And my job at Starbucks has kind of been a little stressing me out. It's a pretty normal thing, kind of like I said, when we're hanging out at parties or at a friend's house. It's not like we're getting drunk or doing hard drugs. I guess it just makes everything more funner.
Okay. All right. So it sounds like you like to relax and have fun when you're smoking with your friends, and you see it as not as bad as like harder drugs. So I'm curious. Are there any parts about it that you don't like?
Yeah, I guess I don't like feeling tired the next morning, having a sore throat, and I don't like the cost of it either. It's quite expensive.
Yeah. Okay. So I see that you marked here that you've never forgotten things when you've been using marijuana. And what that means, just so we're clear, is you don't remember things from the night before. And so that's accurate, correct?
Yeah, I always remember what we did, but sometimes I can't remember what we were talking about. But I also hear that's pretty common with marijuana.
Okay. And I see that you marked you've gotten in trouble. Can you tell me more about that?
Yeah, so my mom has found a couple of roaches one time and a bag of weed another time that I was saving for the next weekend. I ended up getting grounded each time, sometimes for really just a couple of weeks.
Okay. All right. And have you talked to your mom about using marijuana?
Yes, my mom thinks it's a big deal. I mean, I get it. She's being my mom and everything, but my dad smokes, and I know he doesn't really think of it as a big deal. He uses it as medicine. My mom and dad sometimes get in fights about it.
Okay, so it sounds like you're expected not to use marijuana.
Yeah.
All right. And I noticed that you answered no riding in a car with someone who's been using alcohol or drugs like marijuana, and that you haven't driven a car either after you've been drinking or using drugs such as marijuana. Is that correct?
Yeah, that's what I marked.
Okay. Well, that's great. And I hope you continue to avoid those things. However, I do want to know, that I am concerned with your marijuana use. When teens use drugs, things can go wrong, like injuring yourself, even when you don't think you're impaired. Also, between the ages of 12 and 21, your brain is still developing, and it's very sensitive to the effects of things like marijuana. That's why I recommend for people your age, simply wait until you're 21 to decide if that's something that you want to experiment with at that time when your brain is fully developed and you have what's called an adult brain. Okay. Okay, great. So if you were to think about stopping your use of marijuana today, I have here just a little scale. On a scale of 0 being not at all ready and 10 being very ready to change, where would you be for stopping to use marijuana today?
Yeah, I don't know, maybe a 5.
Okay. Okay, I'm curious. Why didn't you pick a lower number, like a 1 or a 2?
Yeah, well, I guess I'm just tired of getting in trouble. And one of my friends who doesn't smoke is giving me kind of a hard time about it as well.
Okay. Well, what could you do to avoid getting in trouble? Have you ever tried not using marijuana or stopping altogether?
Yeah, I guess. There's been lots of times that I've hung out with friends who don't smoke, and not all my friends do it.
Okay. That's great to hear. Some people your age start with trying to stop marijuana for a period of time just to see what that feels like. Do you think you could do that?
Yeah, I could probably do that.
Okay, great. How long do you think you could go without using marijuana?
I don't know.
Do you think you could go 2 months without using marijuana?
Yeah, probably.
Okay. What things would make it easier for you not to use marijuana during those 2 months?
Yeah, I can probably just make up an excuse why I can't. Like maybe not being grounded again. I also can really just hang out with friends that don't smoke.
Yeah. Well, it sounds like you've thought this through. I think surrounding yourself with friends who don't use marijuana is a great idea. That way you don't feel pressured.
Yeah, I guess so.
Okay, so you've come up with some great reasons here that I've jotted down for you to stop using cannabis or marijuana, like having not enjoying the sore throat, feeling tired afterwards, getting in trouble, and you've also come up with a plan to avoid using marijuana in the near future, which I think is a solid plan. I think it's great that you're giving this a try. How about if I have you make an appointment for 2 months from now, and we can see how things are going at that point?
Yeah, okay.
Okay, great. I would like to give you just this little information about marijuana, and it just helps give you some information that you may not see on some of the sources where you're getting your current information on marijuana from. Great. If there's any questions, you can always reach out and call me at my office, and I'd be happy to talk.
Will do.
All right, great. All right. So obviously that was scripted, but we want to make sure that all of the key components are addressed. All right, and so it can be that simple, and that's like I think that was an 8-minute video. So it is something that is very streamlined when you compare it to other things. That are going to be a little more specific to one item. The DAST for drugs, alcohol for alcohol. There's even one for nicotine, but that one you don't see very often. So this combines it all. And what's nice about this is it gives you a lot of information on one page. It doesn't just ask if you've drank more than a few sips of beer. That's not a yes or no question. This is, again, an open-ended question on a form. How many days, right? And so that 12, he wrote down 12, but when you ask the question and you ask for a little more clarification during that, am I, so am I to assume that's about once a month then? Then he self-disclosed, no, I guess, it's more, sometimes 2. And so you actually get more information based off of this form, not being so, check yes or no. And some of the things that about this form, again, is it does really allow for some of those concerns to be addressed, such as that riding in the car. And if you notice, I didn't go in order. All right. And I did that intentionally because, you know, if you kind of slip that car question in there out of sequence, it allows for that that conversation to happen. In his case, he reported reported being a passenger or driving because he is 17. He does have a license. So, you know, just reinforce. Wow, that's great. You know, I'm really happy to hear that you're avoiding that. Keep it up. And again, this is on YouTube. All of these have active hyperlinks. Whoop, I don't want to do that. And so if there's any thoughts or, you know, if there's anything that you have a question about that screening, about that video, or thoughts or comments, anything that you thought was missing or was something that you learned, if you can put it in the chat right now, that'd be great. And then we'll continue. Okay, I don't see anything, so we don't need to have a.
I just saw a question come in, Dave. How often should the screenings be administered?
Yeah, I guess that would be dependent on how often you see you know, the individual. Are you seeing them on a weekly basis? Are you seeing them on a monthly basis, every other month? If you're seeing them on a weekly, you know, obviously that might not be needed every week. If there's somebody like, you know, this, you can probably use it maybe every other visit, maybe once a month. It's really, it would be your discretion. There is no limit or, you know, time sensitive. So yeah, so if you wanted to use it every week, if that person is reporting, you know, daily use of cannabis, and you know, you already are working with them for you know, maybe depression or anxiety, and you want to give this to them every week, theoretically you could. It might be a little you know, repetitive for them, but it also might open up opportunities for identifying some concerns, because who knows, it might change from one week to another. They might have driven in a car with a friend during that week. But I would say monthly is probably the norm. And what is the youngest age you can use the craft 2.1? Well, I guess really, you know, for you all, I guess TAY's is 16 to 25, but can you use this on, you know, 10-year-olds? Sure. You know, when I was providing, you know, outpatient, intensive outpatient, and you know, medication-assisted recovery treatment, and I do like biopsychosocial assessments, it wasn't uncommon to see, you know, 9 and 10-year-olds reporting smoking marijuana daily. So can it be used on a 10-year-old? Yeah, sure. And should the client complete it themselves and then review together, or can it be completed more collaboratively? So yes, so there's actually both a self-report and an interview. You can do it interview, and it's just that sometimes young people might be more willing to be upfront and honest if they're filling it out themselves. And as you notice, it really turned into an interview with it being completed prior. So I would kind of lean towards having them fill it out themselves and then go into it as that interview, review it with them. Go over their answers. All right. As the video kind of had, you know, I see that you marked here 12. You know, so am I understanding that's about once a month over, you know, the last year? And so that is something that allows for that person now to come back to that question and be like, well, I guess, you know, maybe it's more like twice, 2 times a month. And so, yeah, I think that if the person can fill it out on their own at first, that would be best. Maybe 10, 11, you could do it, interview, but and let's see here. All right, oh, I'm going the wrong way, excuse me. I don't see any other questions. Let me just check.
Yeah, just more comments about it.
I
Good
like
feedback.
how it is more relaxed and conversational and opens up the conversation for risky decisions. Yeah, absolutely. And that is really why the craft was designed, was to avoid that clinical questionnaire that's designed for adults. Just the way that adults that we process information is going to be drastically different than a 16 or 17-year-old does. So having it in that conversational approach is a big deal. So, what would be some outcomes for this particular scenario? Well, the young person has identified their own motivation and reasons for not using marijuana. Are they going to stop altogether? It's to be seen, but it sounds like they're willing to cut down or avoid or hang out with other friends who are not going to be smoking. They've identified those other social options, and they have they have a follow-up appointment to check in on their success. Again, always giving them some information to leave with is always, I never let somebody leave without giving them a little bit of information. It might end up in the trash, but then there's that possibility that it might end up being opened and read, right? And triggering just a thought, some contemplation. So I do like brochures. And some of those brochures are going to be things, if especially drinking in your pregnancy. This is one when I do those college events. We have 5 minutes, right, Leah? Okay. So, when I do those college events, if it's a guy or a girl and they mark yes, they drink alcohol, both of them walk away with one of these, because FASDs are both a male and a female issue. It's not just female, right? And then if somebody is taking medication for a mental health diagnosis, being aware of harmful interactions. And what we're seeing now too is, and I haven't been able to find a legit brochure on marijuana and medications, but what we're seeing is that cannabis interacts negatively with certain psychotropic medications. So, these are all going to be resources that you can give a person. How to prevent alcohol-related problems. This is going to be really that 18 and older population that I would give this to, that college age. Also little back charts, right? Those little back blood alcohol content. You find your weight, the number of drinks, it tells you what your blood alcohol content is. We hand those out at college events too. Not to promote drinking by 21 and under, but to raise awareness that, hey, did you know that if you drink 2 beers, you're gonna probably get a DUI? So harm reduction in that matter. I don't give minors back charts. We can all make someone's life healthier. We can help identify individuals who would benefit from changing current patterns of ATOD use. We can provide them with information. We want to provide a recognition. We want to promote the message of hope, self-advocacy, provide assistance when needed, and link them up with community resources. And if needed, refer them, link them to referrals. Sometimes a referral is going to be like, hey, I would think it would be great if you would call this number for an assessment. You can, if you're going to be in an office with them and you're in your office setting, you're seeing them for, a mental health session, you can always say, hey, I have this number, we could call and get you an appointment. You can do it there in your office. So referrals look different depending on the setting. But if they're not willing to do so there, and you don't have a list of local providers, you can always go to the national helpline, and you visit the online treatment locations and you put in your zip code and it'll give assessment sites. So with that, I am on time for this one. We were a little short on the first one. Let's go ahead and do some Q&A, and we'll put up the chat there. And the last one I see is I like how it is more relaxed and conversational and opens up the conversation for risky decisions. Yeah. So if there are any questions or other comments or thoughts, then, you know, it'd be great to have everybody share that.
Dave, I was chatted a question. What do you do if you have a youth who seems to be holding back information, but you suspect is using?
Yeah, I see that a lot. And I just meet them where they're at. You know, if they're reporting, you know, I only use it, you know, once or twice a month, but they're displaying all of the, you know, signs of, you know, maybe daily use or something, you have to go with what they give you, you know. But that's where that exploration and that motivational interviewing is really great, you know. And so when they're reporting, you know, twice a month use or something, you can be like, well, do you have any concerns if it was to turn into something more frequent, like weekly or daily use? And that might allow for them to talk about, well, I'm not really worried about that, or yeah, I guess it might impact their grade, you know, my grades or friendships. And then you could just be like, you know, you could respond and be like, well, how do you think it might impact those friendships? And you might want to kind of continue to have them share that. And it might come out that they're going to disclose that, well, I actually do use a little bit more than what I shared. And I've noticed that in my own friendships. But we can't force and we can't coerce. We can only work with what they give us. We got to meet them where they're at. It's tough because I've done this program, Teen Intervene, with youth who, you know, are referred for use and they stick with their story, and I work with what they've got, and I have that gut feeling that they're not being upfront, but you know, you gotta give them what you can with what they give you. So hopefully in the future they'll get the services that they need. Okay, I think I don't see anything else. You will get a copy of these slides. So all of the links are there. There are some videos for oars and frames and readiness ruler. So I hope you've found this beneficial. It is 11:50, so I'm going to hand it back to Leah.
Thank you, Dave. Thank you, everyone, for coming today. We do appreciate it. Next week is our second series where we will go over the navigating the programs that are in Bucks County, which is the assessment sites and other programs that adolescents are able to use. So I know I was chatted that question. So there is a separate registration for that for day 2, which is next Monday, the 16th, that we will be able to come back together. I'm going to put the CE certificate information in the chat right now, which is a link. You'll complete the post-test and evaluation in order to get your CE certificate or your certificate of attendance. It looks like there's a lot of different comments in here. Dave saying really great presentation. Thank you, Dave. Everything was very helpful. The registration is a separate one for next week. There's another question about that, so I can send those out as needed, who need the registration for next Monday to join us. I don't think there's any questions coming through. I think just positive comments for you, Dave.
Thanks so much, and really appreciate you all attending today. And if there are ever any questions, you can feel free. If there's resources that you don't, having a hard time finding, I'm putting my email in here so that you can reach out to me, and I'll get you some links to brochures or resources, or even answer any more questions more in depth too. Great. Thanks so much, everybody.
Thank you, everyone.
Thank you.